Well, good afternoon, and welcome to Tuesday, the 36th National Week of Prayer for the Healing of AIDS. As always, I am just absolutely ecstatic that you have joined us one more time again for this noonday, the doctor and the preacher. And thank you for all of you who have been on this journey with me for 36 years. You know, we started in Harlem. God's grace is just sufficient for the journey. As I started to share with you yesterday, you know, this is a little teeny weeny idea that God placed in my soul and in my heart. I was transitioning from being a research scientist to working at Harlem Hospital, and I was just absolutely devastated that the hospital was filled with patients with HIV and AIDS, and there was no preacher. The church people were not coming. Mamas and daddies and brothers and sisters were not coming. They had left their loved ones to die alone. And I just could not understand that because, you know, I'm from Lincolnville, South Carolina. And in Lincolnville, when folks were sick and the folks died, you know, the community rallied around them. You know, a pound cake started getting baked and people started bringing Coca-Colas. And I mean, when someone was sick, you had a house full of folks. And when someone was dying and when someone died, the community was there. And now I'm in Harlem Hospital, and we have a community that's being devastated by HIV and AIDS. And where is the church? Where is the mosque? Where are the religious folks? Where are the folks who declare that God is everything? And in my prayer, God said, a Harlem week of prayer for the healing of AIDS. I want to just take a minute, as I did yesterday. I lift up Dr. Preston Washington and Reverend Dr. Wyatt T. Walker and Canon Frederick Boyd Williams yesterday. Today, I want to lift up Bishop Norman Quick. He was our chair that first Harlem Week of Prayer for the Healing of AIDS. And it was just really a testament because these were people, religious leaders in Harlem that were silent. But the week of prayer opened them up to think about how their response was really doing more harm than doing good. It provided an opportunity for them to repent, an opportunity for them to share their growth in this movement. And I remember Bishop Quick standing tall and saying to the people that, you know, this is Bishop Quick in 1989. He said, you know, I had sent a lot of homosexuals to hell. But when my nephew got HIV, and I could not send my nephew to hell, and I could not send my sister to hell, that was a revolutionary moment because everybody, I believe everybody has a space at the altar. Everybody, God's love, God's grace is sufficient for everybody. And it was Bishop Quick who put that out, just like Reverend Dr. Y.T. Walker, as I stated yesterday, proclaimed that by 89, he had already buried 75 men from his choir. It was a revolutionary moment, but it wouldn't have happened if the religious leaders, the religious community of Harlem, did not say yes. I was not clergy. I was just a little girl with a little idea. And I didn't know no pastor. And I just will always give homage to Bishop Quick and all of them. I could never recall all of their names. Imam Ali Rashid, who at that time was the leader of the Masjid in Harlem and opened up his doors, and I was welcome in the Masjid. We did so much HIV/AIDS awareness programs in the Masjid as we did in the church. It was a time, the idea was to bring not only Christians, but Muslims and the Ethiopian Hebrews. The oldest synagogue in New York City is located in Harlem. The Native Americans, surgerymen from the Yoruba community in South Carolina came up. The children of Obatala came up. It was a glorious, glorious moment. I have some pictures that I just want to flash around the on the screen to you. It was really community organizing at its best. And remember, I had no clue what I was doing. But God, when God gives you an idea, he will bring everything and everything that you need to you. And this picture is just a community of all faiths. All faiths, Black people of all faiths who believe in the one God. And it was just, I can only say thank you to every person in that picture and all of the folks who followed them. Let's just move quickly. We are walking around Harlem Hospital that first week of prayer for the healing of AIDS. We are walking around in a consciousness of prayer to stop the spread of HIV and AIDS. And I'm sure many of you who are with us today, you are recognizing some of these folks who are still with us, and most of them are still on the other side. And this is a picture of me on the stage, Imam Rashid, surgeonman from South Carolina who came up, brother Imam Talib, who was a brother then, and Little Flower, the Native American. I wish I could just go on and on and on, but time will not allow. But my point is 2 points. When God gives you an idea, move forward. He will bring everything to you. We did not know that this little idea would give birth to the Balm in Gilead, now an international organization. Today, we continue to move the Balm in Gilead with the doctor and the preacher. The two most important, put that slide up again if you can, the two most important people in our lives is the doctor and the preacher, or the preacher and the doctor. It is always important that we have these two. And this picture is Dr. Benny Prim. Dr. Benny Prim, who was an HIV advocate and each HIV/AIDS researcher, a prominent physician, but he was a fighter. He was a fighter. He led the HIV/AIDS movement in this country. And the Reverend Dr. Calvin O. Butts III, at that time, the senior pastor at Abyssinian Baptist Church. They are at a Harlem Week of Prayer program. Justin Benny Prim is sharing with the preacher the facts around HIV and AIDS. And that's what's key. It is so key that we all are on the same page with the facts, And we continue to pray for the healing of HIV and AIDS, people who are living with HIV. African Americans, we still have the highest rates of HIV. Black women still have the highest rates of HIV and AIDS. We thank God for, tremendous treatment. We thank God for all of the scientific breakthroughs we've had with HIV and AIDS, but there's still no cure. So I'm going to get out the way. We have a tremendous panel today. My two guests for today, if I can get my notes together, they're always not ready when I am ready. We are so happy. Our topic today is understanding current trends of HIV policy. Understanding current trends in HIV policy. Policy is so key for the Black community, and our voice is often not heard when it comes to policy. Dr. Cedric D. Pulliam will be our HIV policy expert, followed by our faith leader, Elder Will Francis, the lead parishioner at Lives and Souls Global out of Atlanta, Georgia. Again, thank you, my sisters and brothers, for joining us. And now I'm going to turn it over to Dr. Cedric D. Pulliam.
Good afternoon, good evening, or good morning, depending on where you are joining and watching us today. Thank you so much for the Balm in Gilead for allowing me to present some of the current HIV policy trends here in the United States. Let's go ahead and start and get the slides up. All right. So I'll be again talking about current trends. Next slide, please. So, the biggest hot topic in the US HIV policy field is really around the budget debate and debacle that is happening in Congress, where we are still at a continued resolution and a stopgap bill, which basically the stopgap bill provides a placeholder where there's a time frame allowable for both houses of Congress to get in their votes and then also review the budgets by agency in the federal government, which is a lot, as we know, but by agency, and have a deadline set for the budgets of various agencies to be completed at a specific time. And so it's a almost a placeholder to not do a government shutdown. It's like one of the last resort placeholders from the federal government sense. And so we are currently in what is known as a continued resolution that for the fiscal year 2024 budget and a stopgap bill to avoid a government shutdown. And so it's important to remember in the policy point of view where we have come from, because Dr. Seal has mentioned 35 years of this particular week. And in the 80s and the 90s, government budgets around HIV were very slim. And now we are at a place in 2024 where things are really in a good place. They could be better, they could be more exceptional and more larger. But let's talk about the budget by agency at the current standpoint of the fiscal year 2024 request from President Biden. So at the CDC level, domestic HIV prevention funding was at 1.2 billion in the request. So this is 14% higher than last fiscal year 23's enacted level. Enacted means how much was actually enacted and approved and was able to be utilized from CDC's domestic HIV prevention portfolio. HRSA, the Ryan White program, is at 2.7 billion in the request, which is 5% increase, all thanks to the Ending the HIV Epidemic Initiative. So the EHE has been able to allow for a 5% increase to the Ryan White program in the request. Additionally, the health center programs, which is workforce and different health centers around the US, are at 127 million, all thanks again to the US Ending the HIV Epidemic Initiative, or EHE. The National Institutes of Health domestic research portfolio was at 2.7 billion, and it saw a less than 1% decrease, so a total of 1.3 million decrease from the previous fiscal year. The Indian Health Services that serves our tribal reservations and tribal communities throughout the U.S., and particularly their health and HIV programming, is at $52 million. The Housing and Urban Development, or a HOPWA program, which provides housing program and housing opportunities for people living with HIV, is at 505 million. And this new one, the Mandatory Pre-Exposure Prophylaxis, or PrEP program, this is a call to action and an advocacy call to the U.S. federal government and the Biden and Harris administration to really bring pre-exposure prophylaxis, or PrEP, to a mandated component where there is a set aside amount of funding for PrEP to be able to, educate folks about PrEP, navigate individuals around PrEP, and retain individuals on PrEP throughout the United States. Because, and what I will discuss later in this presentation, is to why this is such a call to action and a high need, because as much as our PrEP numbers look good, it's not good across all communities, all demographic or racial or sexual orientation, gender identity demographics. And so there's a lot of things to work on. This is at a request of $237 million, but this is by year. So the request in the fiscal year 2024 budget is for a 10-year program, so 2024 to 2034, at a $9.8 billion over the 10-year period, so $237 million per year. And this is also in that request. It talks to the Center for Medicare and Medicaid Services, or CMS, to really focus on expanding access to PrEP under Medicaid funded programs. And that's a very important element because, as we know, Medicaid expansion in the U.S. South and the southern states has not occurred, particularly where I'm in right now in the state of Georgia and across the southern US. And so, again, more expansion to PrEP and Medicaid programs that will help both non-expanded Medicaid and expanded Medicaid based on the language in the funding request for fiscal year 2024. And the Minority AIDS Initiative that is managed by HHS, or the U.S. Department of Health and Human Services, Office of Infectious Disease and HIV/AIDS Policy, is at a $105 million. And next slide, please. Some of the policy areas focus also on an intersectional lens of legal matters. And one of the most important things, and you can see my lapel pin here, HIV is not a crime. I'm a huge, staunch decrim advocate in the HIV criminalization space. And we just celebrated last week on February 28th, the national, but also now global HIV is not a crime awareness day here in the US and around the world. So one of the key policy goals here is around passing the repeal existing policies that encourages and allow legal, aka the Repeal HIV Criminalization Act, or the Repeal Act. And that is consistent with current HIV decriminalization advocates' understanding and strategy, and incentivizes states to modernize or repeal their respective laws. What really here is important to know is that there are over 30 United States state governments that still have HIV criminalization laws on the books and are actively executing legal issues around HIV, specifically around a person's status in those states. And so HIV criminalization, to give a very quick summary background, were laws that were created in the 1980s for states to be able to receive federal funding through programs that were created, like Ryan White program that I discussed, that really does provide HIV care, treatment, and retention services for people living with HIV, as well as other federal funding elements. And so they required these states to have these laws because it was HIV at that time in the 1980s was very unknown. And it was a lot of stigma, a lot of discrimination, and a lot of negative energy around HIV. And those states were required to have this to get funding from the federal government. And so the core issue was the federal government requiring this of states to receive funding, because once they enacted these laws, most of them kept them on the books until advocates, people living with HIV, their co-conspirators started really uprooting and coming to the floor with creating task force coalitions and working groups to really demand advocacy around repealing or modernizing HIV criminalization laws in their respective states. And the next bullet here, of course, that I'm just mentioning is enacting legislation encouraging and supporting states to repeal HIV crim laws. And then lastly, molecular HIV surveillance, or MHS is how it's known. So basically, advocates, and I want to give a shout out to AIDS United and the AIDS Watch kind of policy priorities, because this is still gleaming even into 2024's policy priorities as we prepare for AIDS Watch in a couple weeks, in Washington, D.C., to advocate to all of our different Congress members around HIV specific policies that need to be of attention of theirs in their legislative year, and thinking about what they need to do from the federal level, talking to their state comrades at the state legislative level to really start generating momentum and getting some of these wins and successes for HIV advocates writ large around the United States. So molecular HIV surveillance is a way that is being impeded on in regards to the ending the HIV epidemic. And it's in the response pillar, where basically looking at clusters of HIV incidents in a particular region or area within a state or a local community, and being able to understand kind of the understanding around the molecular, genetic, and DNA evidence around that particular cluster. And so the real call here is that any public health strategy for ending the HIV epidemic must be built on a strong foundation of trust. People living with and vulnerable to HIV must be able to interact with the healthcare system without fear or stigma or discrimination of having their lives or their sero status weaponized against them in the future. This is important because law enforcement, district attorneys, etc., have utilized a person's HIV status against them and criminalized and imprisoned them. And so this is very important for people living with HIV and those vulnerable to HIV. And if the benefits of MHS are ever to outweigh the risk, the individual rights and privacy of people living with HIV must be prioritized, and the concerns of the HIV community must be addressed. This is very important. Next slide, please. So quality of life of people living with HIV, some of the policy trends here is healthcare access is important. Expanding Medicaid to improve equitable access to healthcare. Still have 12 states have still not expanded Medicaid. In states where Medicaid has been expanded, only 5% of people remain uninsured, compared to 19% in states where Medicaid has not been expanded. This is vital. This is a call to action for those who are vocal at the local or state or county levels in their state to really ask and make sure that your state has Medicaid expansion. And if it does not, like the state of Georgia, work with your state legislators to get this passed. A majority of the states that have not adopted Medicaid expansion are in the South, as I mentioned before, where approximately 45% of all people living with HIV in the U.S. reside. Think about that percentage and that statistic. Housing is a big piece. Fully fund HOPWA and other federal housing programs and enforce the Fair Housing Act to address housing discrimination. This is very key and very important. Employment, support economic justice and employment for people living with HIV. People living with HIV must be able to live without negative employment or economic consequences related to their health status, disability, sex, gender expression, sexual orientation, family responsibilities, race, or ethnicity. And then, of course, we know reproductive rights and reproductive choices have been a huge hit after the Roe v. Wade decision recently in the past year or so. And one of the elements here is that we must think about, factors that lead to a lack of access to equitable reproductive care, but often the prohibitive costs of healthcare, stigmatizing experiences in the healthcare settings, and discrimination are to blame usually. And this is important so that we have culturally relevant, non-stigmatizing, comprehensive sexual and reproductive health care and rights is essential for the quality of life of people living with HIV. And I say quality of life because a person living with HIV, once they can get a diagnosis, in the context, even today in 2024, it's still entrenched with stigma, it's entrenched with discrimination, it's entrenched with blame of that person. And until we start unpacking and deconstructing and restructuring how we think about HIV, about the person, the human, until we center that human context, quality of life is important to keep at the forefront of policy, laws, and any other elements of the healthcare and public health systems. Next slide, please. Prevention is important. So pre-exposure prophylaxis, this is important because the CDC recently released in 2023 their PrEP results at the national level. And I want to go over some of the statistics, and I want to appreciate my colleagues at AMFAR, or the Foundation for AIDS Research, to really showcase some of these distinct differences and inequities. So nearly all white Americans, 94% who could benefit, received a prescription for PrEP last year, but only 24% of their Latina and 13% of their Black counterparts access PrEP, despite their disproportionate need. For example, 40% of new HIV infections in the U.S. occur in Black people, Black communities, despite accounting for only 14% of the total population. Additionally, gay and bisexual men accounted for most new HIV infections in 2021, and the majority of them were among Black or Hispanic or Latina individuals. So the CDC shows that racial divisions in PrEP access are only widening. While the number of white Americans on PrEP has grown by 34% in 3 years, the growth among Black Americans over the same period only at 5%. So the overarching question, a continued gender, racial, sexual orientation gap exacerbates PrEP success for those with higher annual incidence of new HIV diagnosis per year. And for a national PrEP program, remember that mandatory national PrEP program during the funding discussion that I provided previously, what innovative solution will truly make the difference? Should it be the onus on providers ensuring that PrEP is a general concept that they offer patients regardless of this risk or this incidence analysis that they do? Should pharmacists have the ability to prescribe and retain clients to PrEP in their state? Or what is that innovative solution? The pharmacist piece is important because we saw in states like the state of Virginia, where they allowed this for pharmacists to navigate and prescribe PrEP, we see higher numbers of new PrEP users within the state of Virginia's context, as an example. Next slide, please. So what is the president and the current Biden-Harris administration looking at around HIV policy and the trends? So the National HIV/AIDS strategy, that the most recent one that was executed by the former director of the Office of National AIDS Policy, Harold Phillips, a friend and colleague of mine, worked hard and diligently to ensure that this interim action report was produced as well. And so this interim action report, and the link is here, and hopefully this is shared widely to the audience. And this is a report that's showcasing by agency and by the National HIV Strategy goals that were laid out in the revised strategy, achievements and continued areas of focus by these goals. And so it's important, and I won't go, and it's a lot to discuss and I don't have the time, but I don't want folks to not check this link out. Please check this interim action report and learn what the different agencies are doing and what they have achieved, what they're continuing to focus on, and how you can track that. These are sort of elements that are important as advocates, as a person living with HIV, as a person vulnerable to HIV, or just someone in this HIV workforce. These are things to make sure that you are knowledgeable about and you pay attention to. And some of the administration policy goals are listed here: implementing a multi-year HIV research plan, beginning a new clinical trial of an HIV vaccine, facilitating the linkage of HIV services to harm reduction programs, promoting the equality, dignity, and safety of transgender Americans, improving health outcomes for people aging with HIV, diversing the President's Advisory Council for HIV and AIDS membership, engaging with the HIV community, and affirming the undetectable equals untransmittable message, where a person living with HIV who takes their HIV treatment as prescribed is zero risk to transmit HIV to their sexual partners. And I want to say that many of these elements have been executed, like diversifying the PACHA membership, really well done. I think 13 new members, diversified ages, backgrounds, expertise levels, as well as racial and sexual orientation and gender identity inclusion in that. And again, engaging with the HIV community, there has been various listening sessions held throughout each region of the United States, and they will continue throughout 2024. So they are doing work around this and facilitating the linkage of HIV services to harm reduction programs. Recently in Omaha, Nebraska, we saw the governor really showcase the disconnect here around why harm reduction programs are not promoting drug use or syringe use to the population or to children. What it is showcasing a safe haven and a safe prevention and treatment mechanism for those who do use drugs, to be able to provide them with support services in the harm reduction and trauma-informed and people-centered approach. Thank you. Next slide. That's all. Thank you so much for having me, and I will pass it back over. To Elder Will Francis. Thank you so much.
Well, God bless you. God bless you. Having a little internet issues over here, but really excited to be here. I want to thank Dr. Seal for the invitation, to Elder Carrie Goodman, as well as to Dr. Pulliam. I tell you, the doctor and the preacher will preach all day. I'm like, it will preach all day. The preacher and the doctor said, but they have asked me to do a devotional just to land this thing on today. And I want to just take your attention to Proverbs 31:8. Proverbs 31:8. And I'm going to go ahead and read the NIV version. Speak up for those who cannot speak for themselves, for the rights of all who are living with HIV. I've adapted a little bit, but speak up for those who cannot speak for themselves. Look, throughout the sacred text, we see scriptures on justice, charity, love, and mercy. We see scriptures on clothing the naked and feeding the hungry and visiting those in hospitals as well as jails. But as people of faith, we are called to embody compassion, justice, and love for all members of our community, especially those that are marginalized and vulnerable. In the context of HIV policy, our role as advocates is equally as important. And it becomes paramount in ensuring that individuals living with HIV receive the support, care, and dignity that they deserve, free from stigma, from judgment, shame, as well as criminalization. And the stigma surrounding HIV persists. Let's go ahead and address that up front. It leads to discrimination, lack of access to healthcare, inadequate support systems for those living with this virus. However, the followers of Christ, those kingdom keepers, that we are called to challenge this stigma and work towards creating policies that prioritize compassion, inclusivity, and justice. And for some, I understand that that may be a heavy lift, especially if we look at it through the lens of religion, through denominationalism, and faulty theology. But the kingdom mandate is made clear here in Proverbs 31:8. And we are reminded to speak up for those who cannot speak up for themselves. Now, this verse serves as a powerful kingdom mandate for us to be the voice for individuals living with HIV who may be silenced or ignored by society. Now, look, they may not, and I don't want to say that they cannot speak for themselves, but they do not have the same platforms that faith leaders have, especially on the political and governmental mandates, right? Their voice is silent, and they are not given the opportunities to share their stories and lived experiences. And I truly believe that we have to begin to offer compassionate care, right? And extend the hand of compassion and support to those living with HIV and their families, showing empathy, love, as well as acceptance, and embodying the teachings of Christ to love our neighbors as ourselves, right? And this week, I think it gives us a perfect opportunity with the National Week of Healing for the HIV and AIDS. Dr. Pulliam just talked about policy engagement, right? And how we need to engage with policymakers to advocate for HIV policies that prioritize prevention, prioritize treatment, prioritize support of these services that are so very needed, right? We have to advocate for funding for the research, education, and access to affordable health care for those living with HIV. We must expand Medicaid in the southern parts of the US, where the burden of newly diagnosed individuals is just so prevalent among the other determinants of health. Systematic racism, we're talking about poverty and equity, said as well as discrimination, which actually contribute to the spread of HIV and hinder access to care. We must begin to offer community support and create safe spaces within our faith communities. The Greek word for sanctuary means safe spaces where individuals living with HIV feel welcomed, accepted, and supported. And yes, that means in our main sanctuaries as well. I'm not talking about a space over on our North campuses. And even there, we must do no further harm, but create a space where individuals can be healed and made whole from church hurt as well as religious and other traumas. We can offer pastoral care, counseling, as well as practical assistance to those in need. We must get educated and be made aware. Educate ourselves, educate our congregants, educate the community and others about HIV prevention, transmission, and stigma reduction. We have to use our platforms to spread accurate information and challenge misconceptions and myths around HIV. And as again, we commemorate this National Week of Prayer, we must be guided by the principles of love, compassion, and justice found in the teachings of Jesus Christ. We need to be bold and brave in our stance against stigma and decriminalization, and unwavering in our commitment and creating a world where individuals living with HIV, regardless of gender, regardless of sexual orientation, are treated with dignity, respect, and compassion. So if you will, just bow your heads just for a moment as we pray and ask, oh God, to grant us the courage and the wisdom to be advocates for the lost, the last, the least, the left over, left out, and left behind, as well as those living with HIV. Oh God, may we be guided by your love and compassion as we work towards creating these policies and communities that embody justice and inclusivity. Oh God, we ask that you give us the strength to speak up for those who cannot speak for themselves and to be agents of change, catalysts, and movement leaders in the world as we look to end the HIV epidemic. Oh God, your will, your way on today, Heavenly Father. Said we thank you for this is our prayer. And I pray this knowing that our prayers and our answer to our prayers cannot remain in heaven for long. We thank you, and I turn it back to Elder Goodman.
Well, thank you so very, very, very much. Thank you, Elder, for that inspiring message, for the prayer. Thank you, Dr. Cedric Pullman, for our HIV policy discussion. Thank you all for being a part of today's conversation. I invite you to come back tomorrow, our last day in this series, Monday, Tuesday, and tomorrow is Wednesday. Wednesday, same time at noon, our guest will be talking about HIV research and Black women. HIV research and Black women. Our guest will be Dr. Tamara Taggart, Assistant Professor, Milken Institute in the School of Public Health at George Washington University, and Reverend Dr. Dominique Robertson, Assistant Professor of Preaching at the Seminary of the Southwest and an elder in the AME Zion Church. Thank you so much. Enjoy your day, and we'll be looking for you right back here tomorrow. And don't forget to pray the 36th National Week of Prayer for the Healing of AIDS. God bless you.